Minimally invasive surgery and endoscopy have altered and defined the landscape of surgical training over the last several decades. Both interventions are vital to a surgeon's armamentarium. Over the last 5 decades, Dr. Jeff Ponsky has been an innovator and educator in these evolving aspects of surgery.
I have a boring life story in that I was born in Cleveland, Ohio, and lived there my whole life. My father was a blue-collar worker. He owned a used tire store, and I used to help him in the store. We used to pick up used tires from gas stations and rehab them a little bit and sell them for $2 a piece. And we sometimes made retreads, recaps. We didn't make much money, worked pretty hard, and we stayed in Cleveland. I went to Cleveland Heights High School, and I was a really bad student because I never even took my books home. Uh, I always wanted to be a doctor, but I didn't act academically like I wanted to be. I was actually told by my high school guidance counselor in the 12th grade, perhaps you ought to do your parents a favor and go to trade school. And so I became a surgeon. So there was something, role models mean so much. And my mother's brother, his name was Bennett Levine. He was an elegant gentleman. He was a Renaissance man. He was a physician, a hematologist, but he was also a concert violinist. And I spent a lot of time with him when I was a young man, and he saw me sort of wandering aimlessly at age 14. He took me down to the hospital. He said, "Come on, let's go and I want to show you what they're doing in the laboratory." And I'll never forget, I saw an animal operation. It was an experiment in translocating the spleen from below the diaphragm to above the diaphragm to look at its function, and that hooked me. So my uncle, again, after when I was 16 or 17, just graduated from high school, said, "Let's get you a summer job at the hospital." The hospital was called Mount Sinai Hospital in Cleveland. That's where he worked. And first I was an orderly. And Fred, I got to tell you, when I put on those pants, starched white shirt, I was so proud. And I felt so important to be a part of the healthcare team. I emptied bedpans, I made beds. We did things that weren't very glorious and glamorous, but I was proud to do it. And the next year, they said, "Well, how would you like to," they had a program, "How would you like to be a surgical tech? We'll train you to be a surgical tech in the operating room." So I was trained, and I worked there for 7 summers. And I was a second assistant and even a scrub nurse. And I was a lousy scrub nurse. I don't think, because I was looking at what they were doing and I wasn't paying attention. But when I got to medical school and I took my surgical rotations and my GYN rotation, I could suture better than the residents could, because I was doing this in the summers and they would let me close the bellies. And I got to be pretty good suturing. And I said, well, heck, this must be something I'm going to go into. And I love surgery, and I went into it with an aptitude, I think. I met her after I graduated college, just before my first year of med school. Uh, she has been, having, and I'll talk about that later, but I do think that having someone in your life to share the good and bad times with, to correct you when you're wrong and encourage you when you're right, that makes all the difference. And that was my wife, Jackie. We've been married about 54 years now. So my residency was at Case Western Reserve, and it's a funny thing because you interview for a residency, and I interviewed at a lot of good places, and I was in AOA, and I thought I was pretty good, but later on, years later, I became the chairman of the department at Case, and I found these old files, and I pulled them out, and there was the record of my interview, and I looked at it. Some urologist interviewed me, and he said, "He's okay, but we could do better," and they were probably right. then we had elective time, and I figured I got to get an elective that's easy. I don't want to be on every other night in my elective. And I happened to walk through the ICU one day. I saw these gastroenterologists fiddling around in a corner with this new endoscope. I mean, there were 6 of them around an upper endoscope, and they couldn't figure out which end to look in. And they were trying to do it, and it was brand new. So God help them. And I said, "Oh, that's perfect. I'm going to sign up for that, and I'll screw around for couple of months, and I'll be done." But once I got there, I worked with these guys, and Jim King and Jerry Smith were super. And they were using Olympus instruments, which were better than the ACMI instruments that they were using at University Hospital. And I did almost 500 cases with them. A lot of uppers, but we were doing colonoscopies. We couldn't get to the cecum routinely because we didn't have a long scope. It wasn't even invented then. But Jim was one of the best physicians I've ever met, a great role model, a great person, and he let me be creative. So the first thing we ever did, and I said, "Jim, look at these polyps, and you take out these big polyps. What are you going to do if it comes back cancer? Where's the surgeon going to take the piece of colon out?" And he said, "Well, I'll tell him it was in the sigmoid colon." So I was reading about what was going on in England, and that they were marking the tips of polyps. Basil Morrison was marking the tips of the polyps with India ink, and he would then look what happened to the polyp over time. I said, "What if we inject some India ink in the base near where this polyp was taken out, and maybe the surgeon will be able to see that spot if it's a cancer?" And Jim let me do it. No IRB, no nothing. We just went to a bookstore and got Pelican India ink. It cost me $160 for the injection needle from Olympus. And we did it, and it worked. And that was 1975, endoscopic marking of colonic lesions. And that probably was very important because people still use, even in the laparoscopic era where you can't touch the colon, you can see that spot. So that is still used today. And that was a combination of surgical thinking and GI thinking together. And that was important. So I went to my chairman, Bill Holden. He's the chief of surgery there. And I said, "Dr. Holden, I can do this. Can we get a scope and do this?" He said, "I would love to do it. We don't have any money to buy the scope." It was $5,200 at that time, multiples of that now. And he said, "But I'm sorry." So this was in the summer of 1974, summer of 1974. And I was at a family party around Christmas time. And I was telling the stories to my brother-in-law, and my mother-in-law was sitting there. And I said, "I'm stuck. I can't do anything. I have no scope." Next day, I get a call. I'm on call at the VA hospital. She said, "I'm going to buy you a present for Hanukkah. Go buy yourself a scope." And she bought me my first scope. In those days, I kept it in the trunk of my car. We cleaned it before we used it with green soap. That's what we did in those days. And the GI guys didn't want to touch babies. And I was doing this. They hired a pediatric gastroenterologist, Michael Gowder, brilliant, innovative, wonderful guy. And they'd be his patients, and we'd be scoping them. And we noticed the light shining through the belly wall. Michael would put his finger and we see the indentation. That led to the PEG procedure that we did. But my wife said, "Take a shot." My mother-in-law said, "Take a shot. This may be good." It was the best decision because what it was a platform for growth. It was a chance for a young man to emulate some greater teachers that he had met along the way, and to make mistakes and correct them, and to learn to be a leader. And I was chairman there for 18 years. Well, I was in something called SAGES, and SAGES was born during that time. I wasn't sure I wanted to join in the beginning. Who were these rebel guys? I was involved with the American Society for Gastrointestinal Endoscopy. It was sort of cool. I was on the board of the Medical Endoscopy Society, destined to be their president through ascension. And all of a sudden, Jerry Marks and other guys start this Surgical Endoscopy Society. At first, I thought they were a little off. But then I realized very quickly that the papers presented there were different. They were surgically oriented and how to use endoscopy to solve surgical problems. And I was very involved with SAGES. And then all of a sudden, 1989, at one of the meetings in Louisville, Kentucky, we have Jacques Parasat present a video in the exhibit hall on how to do a lap chole. Well, the world went on fire. But what we did is we learned it quickly, and we started using our laboratory at Mount Sinai to have various types of courses, train the trainers. We trained the trainers at all the major hospitals and training people who were doing surgery. And so that was the transition to laparoscopy.
Dr. Jeff Ponsky's impact on the world of surgical endoscopy has been foundational in 3 ways. First, through the academic advancement of technology and technique. Second, through mentorship, and I count myself among one of the lucky that have been mentored by him. And third has been through leadership, particularly through professional organizations like ASGE and SAGES, to bring the House of GI and the House of Surgery together in the endoscopic field to advance it for the betterment of patients.
But SAGES was ascending as a real powerhouse. And the American Board of Surgery, to their credit, realized they needed inputs from people doing minimally invasive surgery. And they went to SAGES and said, we would be willing to put a member of your society on our board as a director of the American Board of Surgery. That was a big deal. And SAGES was asked to, as all societies were, to give 3 names and let the American Board of Surgery choose one of them. Why they chose me, I have no idea. But I remember the day I got the call, and I just sort of sat there and went, oh my God. And it turned out to be one of the best experiences of my career, because I really did have something to contribute in terms of the educational components of minimally invasive surgery, how to develop questions related to minimally invasive surgery, how to require surgical residents to learn endoscopy, and what to teach them. And it really was wonderful. But then one day, and I get this call from Frank Lewis. I can remember I'm sitting in the locker room, and Frank Lewis says, Jeff, you've been elected the chairman of the American Board of Surgery. Well, I almost needed CPR. I couldn't believe it. I mean, again, I'm a street fighter kid. I didn't have any, I was writing papers. I had academic credentials. I was a professor, but not the traditional Ivy League type stuff. And I was very honored. The American Board of Surgery was a chance to have an impact on surgical residency and surgical training. I'm so proud of the people that I've been able to train and interact with. You and I worked side by side with our fellows. I don't remember whose fellow was yours and whose fellow was mine. All I know is we laughed a lot and had a good time, and I think that's what it's about. The people that I have been able to interact with have gone on to be leaders themselves. Many of them presidents of SAGES and active in the Board of Surgery and things like that. So I think that's the greatest joy in my career, is not doing procedures, although that's the part of the clinical part. But in terms of what I might have accomplished, it's in training people and helping them train others.
Jeff Ponsky has been one of the most influential surgical leaders of the past 45 years. He served as a director and chair of the American Board of Surgery, has been president of both the ASGE and SAGES, the 2 leading endoscopic societies, and also served as vice president for the American Surgical Association and the SSAT. Dr. Ponsky's influence in these regards may be summarized by saying that through his work as a surgical leader, practitioner par excellence, and educator, He has led our field more than anyone else into the arena of endoscopic surgery, including through his training of 35 endoscopic surgery fellows who now carry on his legacy.
Yeah, so that's the greatest part of my life. I always tell the new faculty members when I'm talking to them or when I'm hiring them, if you were given a canvas at the beginning of your life and they tell you to color it in, it's erasable, big circles. And the first circle would be your career, and it would be almost 75% or 80% of that canvas in the beginning. That's what you do every day. And then as you get to be my age, that part of your career, you erase it. It takes up a little corner. You're very proud of it. You've done a great job. But what gives you the greatest joy is the family and friends and hobbies and other activities, philanthropy, because those keep giving to you and those make you a better individual. I'd like them to say he was a nice fellow and a great teacher and a great mentor, and he encouraged me, and he always was kind to people. I think that's what I would like to be remembered for.
After finishing my fellowship in Durham, Jeff welcomed me to the staff at the Cleveland Clinic in 1998. It was a wonderful transition as my clinic and operative days were aligned with his. Jeff was only 30 feet away for any type of clinical or intraoperative question. It was an exciting time also in the late 1990s. Each week there was a new operation or an innovative technology, and Jeff was constantly pushing to stay on the edge or out in front of the curve. More importantly, Jeff and Jackie were incredibly gracious as they invited me to move into their coach house. When I moved, Jeff and Jackie presented me with the greatest housewarming gift. They gave me Casey, their chocolate lab. Casey and I were inseparable. Jeff will always be a colleague and mentor, but he has a special place in my heart for his actions and gestures to a young surgeon just getting started. There are no words that truly express my gratitude and love that I have for Jeff and Jackie. I only wish everyone was fortunate enough to experience this type of social, professional, and familial relationship, since it expands well beyond the boundaries of surgical training and mentorship. Simply, how lucky was I?
Back in the mid 80s, we would go to Hilton Head every year. And I loved the beach. I would just sit there and be happy, and I didn't even go in the water. I just was happy there. And my wife said, "You're so boring, let's go to a dude ranch." At the end of a week, they all were saddle sore, but I loved it. I came home and bought a new place to live and have a big barn with 8 horses in my barn right now. And I ride them about once a week, and I go out and I take care of them. And it's not just about the riding; it's about being with them. It's they say there's something about the outside of a horse that's good for the inside of a man. And I love the horses, and I love being with them, and it gives me great satisfaction. Over the years, surgical endoscopy has changed, and we are not there to inspect the mucosa. I'm not interested. It's very nice. I look at it, I record it, I take a polyps. But what we do now, I like to think of the endoscope as a vehicle, like a car or a bus, that takes us to a site where we can do surgical operations. It's the vehicle that gets us there. And so when we talk about POEM, or POP, or Zenkers, or we talk about notes, or we do something interventional, we are surgeons taking that vehicle, the endoscope, to the place that we're going to operate. And we should do that. And so surgeons do endoscopic surgery. That's what we should continue to fight for.